Welcome to our Facebook Live session about COVID, lung cancer, and other solid tumors. I am your host, Claire Saxton, Vice President of Patient Experience at the Cancer Support Community. For more than 35 years, we at the Cancer Support Community have been a relentless ally for anyone impacted by cancer. We help individuals manage the realities of this disruptive disease and get back to normal. Whether accessing our free services in person at one of our 175 locations, online, or over our toll-free helpline, you're getting a team of licensed professionals providing patient navigation, financial counseling, genetic counseling, pediatric support, and more. I would like to introduce today's speaker, Dr. Carbone. David Carbone is a professor of internal medicine and director of the James Thoracic Oncology Center at the Ohio State University Comprehensive Cancer Center. He graduated from Amherst College and received an MD and PhD in molecular biology and genetics at Johns Hopkins. And after an internal medicine internship and residency at the Johns Hopkins Hospital, he did a medical oncology fellowship at the National Cancer Institute. At Vanderbilt, he was director of the Thoracic Head and Neck Cancer Program and director of their SPORE, which is a large research symposium in lung cancer for 11 years. He was recruited to the Ohio State University in 2012 to direct the James Thoracic Oncology Center. His research interests have been focused on lung cancer and specifically on lung cancer genetics and biomarker testing. Dr. Carbone will help us better understand today's topic of COVID, lung cancer, and other solid tumors. Welcome to the live cast, Dr. Carbone.
Well, thank you very much for that introduction, Claire. I'm happy to be here. So I'm a medical oncologist, not an infectious disease doctor, but I'm happy to contribute what I can.
Great. So we know that when COVID first started, it impacted people's treatment. Treatments got delayed or moved to oral treatment when possible rather than IV infusions. We also know that patients were anxious about were they immunocompromised? And if that's the case, how could they stay safe during the pandemic? So what measures now, where we are more than a year later, what measures have lung cancer centers put into place to keep patients safe during COVID?
Well, that's a complicated question. But just as a general statement, really, COVID has affected every aspect of cancer diagnosis and care. And one of the biggest effects actually has been on the diagnosis of lung cancer or other cancers, because people aren't seeing their GPs. They aren't coming in for minor symptoms to get checked out. They're not getting their screening mammograms or lung CT scans. And so we actually saw for a long period last year a decline of about 50% in the number of new cases diagnosed. And that wasn't because cancer was going away. It was because the diagnoses were delayed. Once you have a diagnosis of cancer, there's a really strong motivation to come in and get your treatments as scheduled. And so we found that our clinics operated within a few percent of the capacity of the volume that we had the year before in terms of administering treatments. But the actual, there were many steps that our center and others took to safeguard patients and staff, including mandatory mask wearing, mandatory temperature checks on the way in, face shields, all of those things, and reduction and distancing, reduction in density in our team rooms, limiting visitors, etc. And we actually had very few cases of documented transmission in the hospital, and actually only one that I know of because of all those precautions that were taken.
So do patients with lung cancer face higher risks of getting COVID? Does a diagnosis of lung cancer mean that you're at higher risk in any way?
So really the risk of getting it is more behavior and exposure. The risk of the consequences of getting it are a totally different story. So I found that lung cancer patients were generally more cautious than the average teenager who wants to go to a bar with their friends without masks. And so they were usually very compliant with mask wearing and being careful. And but the real difference was, I think, especially in lung cancer, where patients start out with lung disease and compromised lung function, and they're older patients in general, they're at a much higher risk of mortality if they contract COVID. I've heard it said approximately a 4 times higher death rate than patients, age-matched patients without lung cancer. So they're definitely, the consequences are much greater.
So those statistics are concerning. And what steps should patients take on a regular basis to stay safe and reduce their risk?
And what I'm recommending now is getting vaccinated now that we have a vaccine. And even patients on therapy, patients who've had COVID, I recommend they all get their vaccines. We've not had a single case of a complication or a interaction with therapy from these vaccines. The one minor exception is we do have some clinical trials that use a chimp adenovirus. So the adenovirus-based vaccines would interfere with this clinical trial. But the Moderna and Pfizer vaccines don't use a virus backbone, so that's not an issue.
Okay, so even for the clinical trials where it might be an issue, there are vaccines that wouldn't be an issue.
Absolutely. And people are concerned if you're immunosuppressed from chemotherapy, we're told not to take certain vaccines, but generally the ones that we avoid are the live attenuated virus vaccines, and none of the COVID vaccines are attenuated virus vaccines. Even the AstraZeneca vaccine is a replication incompetent virus, so that there's no risk even in immunocompromised patients. Now, those patients may not develop the degree of immunity that a normal person would, but it would be some immunity, and some is better than none.
And as the vaccines started rolling out more and more, we saw recommendations from the CDC, the NCCN, and other cancer-related organizations say that cancer patients should be a high priority group for vaccination. Why is that?
Well, just because of their risk of death if they get infected. And actually in my state, I was very disappointed that cancer patients were not prioritized until very late in the prioritization schedule. And these people were coming in saying, if there was any way I could get them a vaccine, yet they weren't prioritized. They were pretty much put in the same category as people without cancer of their age. And other states prioritize cancer patients differently. And I think that really was a mistake. Every state had a limited vaccine supply at the time, and they had to do some prioritization. But cancer patients definitely should be prioritized. And now, with better availability of vaccines, I think certainly that recommendation should be made to all cancer patients, almost all of whom adult cancer patients they're all eligible to receive it.
And what about people that cancer patients are living with? Should they prioritize getting vaccination? Does that help reduce the risk of the cancer patient?
Yeah, absolutely. I think the patient's environment, as I said, the contracting the disease is really related to exposure. And, if the environment of the patient is a high density environment, lots of people in the household, then those people should be encouraged to all be vaccinated and not just the patient, um, to reduce the risk of spreading it. There are cases of vaccinated patients who develop serious disease. So really limiting the exposure is important, and that includes vaccinating everyone in the patient's family circle.
And then once patients with lung cancer or other solid tumors have been vaccinated, is it safe for them to unmask? Or should they still be masking and social distancing even though they have the additional protection of the vaccine?
Well, it's safer once they're vaccinated, and it's 2 weeks after the last vaccine. But with the current environment, there's only about 50% of the US is vaccinated, and the states are relaxing masking requirements. And they nominally say that you're allowed to unmask if you have been vaccinated. But if you look on the sidewalk in town or in the restaurants, nobody wears masks. And so, half of those people, statistically are not vaccinated, yet they're walking around without masks. So I would still be careful, especially in crowded, poorly ventilated situations with people, many of whom might not be vaccinated, that there's still a risk of exposure. But I do think that if you're walking outside, if you're in an open outdoor restaurant, that vaccinated patients should feel free to unmask, because the fact is most cancer, or many cancers, are incurable, and our goal of treatment is to prolong life and give them a good quality of life. And being holed up in your house without any interaction with friends or other family members is not a good quality of life. And so there's a balance to be struck with maintaining a quality of life at the same time as being prudent with your COVID precautions.
Thank you. So let's dig in a little bit in terms of what we know about the safety and effectiveness of COVID vaccines for people with lung cancer. There have been some small reports of the Johnson & Johnson vaccine here in the US having some side effects. Do you see any of those side effects are they any more likely in people with cancer?
We have at my institution, very large, we have thousands of physicians and nurses and healthcare providers, and thousands just in our lung cancer clinic. We see 2,000 new lung cancers a year. And I'm not aware of a single case of a serious side effect that's occurred that can be attributed to the vaccine. Now, many people have flu-like symptoms that last a day or two. They have a sore arm. That level of side effect. It seems like women are maybe more prone to that than men, and maybe the younger people rather than older people. But all of those things are mild compared to getting COVID. So I think that there is really a very high degree of safety in these vaccines. They're very, they've been now tested in millions of people. And I think that they're an absolute win for modern medicine, that we were able to develop such an effective vaccine so quickly.
Great. And then We actually have a question from somebody who's viewing right now, who was diagnosed last year with stage 3 lung cancer, who is fully vaccinated and has developed shortness of breath. They were wondering, could that be a side effect of the vaccine?
It's highly unlikely. And actually, with the, first of all, chemo and radiation therapy, while it kills the cancer, also damages normal lung and causes what they call pneumonitis. And then on top of that, the immunotherapy that's now used also has a reasonable risk of causing inflammation in the lung and shortness of breath. And I would say it's far more likely that the radiation, chemo, and immunotherapy you're getting are causing the shortness of breath than it is that it's related to the vaccine.
Okay. And I assume with any kind of side effects like that, the best thing to do is to talk to your healthcare team, your cancer care team.
Yeah, especially in the situation that was described. We are often finding we have to stop the immunotherapy because of this inflammation in the lung that happens. I wouldn't say often, but something in the range of a fifth or so of patients end up having to stop the immunotherapy. So if you have a significant shortness of breath, and it depends on how long we're talking about after chemo and radiation, usually the effects of chemo and radiation stabilize after about 6 months. You can get progressive shortness of breath up until that time from the chemo and radiation. And then the immunotherapy can cause shortness of breath that occurs in the 6 to 12 month range. And usually people stay on it for only a year. So clearly it should be something you discuss with your doctor. Most of the time you can explain the shortness of breath with what you see on a CT scan. Inflammation in the lungs is often visible on a CT scan. And if there's a thought that it's due to the immunotherapy or even from the chemo and radiation, often a course of steroids is given, which can help reduce the symptoms.
Thank you. And so, are there any patients undergoing active treatment for lung cancer who should not be vaccinated?
Well, for lung cancer, I cannot think of someone who should not be vaccinated. People on active chemotherapy, I mean, you might want to wait until the week before your next round of chemo when your blood counts are back up. But really, the only group that I know that really doesn't respond to the vaccine are people with lymphomas, for example, that are on B-cell targeted therapy. And the B cells are what make the antibodies. And those people really have a very hard time developing antibodies. But with the lung cancer drugs, with the immunotherapies, with the targeted therapies, the risks of getting the disease is far greater than the risk of significant side effects in any patient population. Now, we may end up in a situation where we need booster vaccines, for example, and it's possible that people on chemotherapy would have less of a vaccine response. But like I said before, any response is better than none, and any protection against the virus is better than none. So I can't think of a group of patients that should not be vaccinated.
Okay, and what about longer-term survivors, those not undergoing active treatment? Are there any reasons that you can think of that cancer survivor who isn't undergoing active treatment shouldn't get vaccinated?
No, absolutely. Absolutely not. I think that is a group that definitely should be vaccinated, because even cancer patients who aren't on active treatment, especially lung cancer patients, like we said, had compromised lungs and are more at risk of serious complications or death from the virus. And so they are a group that absolutely should get vaccinated. And I know there's concerns. I would say most of my patients, 90%, jumped at the opportunity to get the vaccine. Um, Better than, higher percentage than the normal population, just because they're in the medical environment, and they really trust their oncologist potentially and his recommendation. But I still have patients who are reluctant to get the vaccine, calling it experimental, and various other reasons. And I try to dissuade them because, for example, cancer patients are often treated with drugs that are new and for treating their cancer, and only have been used in a dozen patients. And now we have 100 million people treated with these vaccines that are safe and effective. There's really no argument that these are still experimental. They're clearly effective and clearly safe.
And one of the things that I've definitely heard, especially from people who are undergoing immunotherapy, is that they're afraid that the vaccine in triggering the immune system is somehow going to interfere with their immunotherapy treatment, and therefore the treatment may not be as effective.
Yeah, I can see that concern. But you have to realize that every day, every one of us is exposed to antigens, things in the environment that your body hasn't seen. We develop immune responses to things in our environment 100 times a day, every day. And all the vaccine is doing is giving you exactly the right antigen to give you a protective immune response against COVID. So it's not like there's nothing inducing immune responses normally. You're constantly inducing immune responses. If you didn't have these immune responses against the bacteria in your environment, you would die probably within weeks. So the fact is that all we're doing is providing one more on top of the 1,000 different things that your body's responding to every day in the environment. We're providing one more thing that's specifically protecting you against that virus. So I think that that's not a concern.
And we have a comment from a viewer who says that they've been doing immunotherapy for 5 years and it's working great. Their lung cancer is stable, and that's part of why they don't want to get the vaccine. What would you say to someone like that?
I don't understand how the connection between the two. Your cancer can be stable, and you can still be on Keytruda. Often we stop Keytruda after 2 years, but if your cancer is doing well and you're out 5 years, it would be a shame to contract COVID and die from that when it could have been prevented. And so I think that you should consider yourself fortunate that you're one of those patients that's done very well on Keytruda. That's absolutely not a reason to avoid the vaccine, because you don't want to survive lung cancer and die from COVID.
And are there any considerations in terms of scheduling or getting results from comprehensive biomarker testing or any kind of other diagnostic testing? Because we've talked about it not being a concern in terms of therapies, except you might want to just schedule it around the time in your chemotherapy cycle where your blood counts are the highest. But in terms of any kind of diagnostic or especially comprehensive biomarker testing, which gives a lot of patients the opportunity to have more treatments available to them, would it affect those results at all? Is there anything that needs to be considered?
Absolutely no effect on biomarker testing with the COVID vaccines. The biomarker testing is usually done on a blood biopsy or on a tumor biopsy. And the results of those are genetic analyses of DNA that have no interaction at all with the vaccine. So I would not be concerned with that at all. The only potential interaction I think we talked about is confusing side effects of a vaccine with the side effect of a treatment. For example, if you have a little bit of a fever with a vaccine, you want to make sure that your doctor knows about that, and that's not confused with a side effect of the treatment. But as far as biomarker testing, really there should be no impact whatsoever.
And do you have any insights in terms of the future of vaccinations or any approaches to vaccination changing, perhaps boosters becoming needed over the coming months? Do you have any ideas if there might be any changes coming, or what would spark a change in what's now recommended in terms of the vaccine schedule?
Well, these are new vaccines. We know that the way we give them is effective. We don't know how long that protection will last, and we don't know until we test it whether some of the new variants that are arising will be covered by the vaccines that we have. And that's why we have flu vaccines every year, because the virus changes every year. And if we find new strains of the COVID virus that are not covered by the current vaccines, we may need to develop a new slight variant of the vaccine that covers this new virus variant. But the fact is that if it is also possible that with effective vaccination, the vaccine's effect will last long enough that COVID will become rare, and we don't need booster vaccines, and this doesn't need to be an annual thing. I think we just have to see how things go. In my state, we're down to less than 2% positivity rate, even though less than half of the state is vaccinated. I'm hoping that trend continues, and that, like SARS and MERS and other kinds of viruses that we've seen in the past, they just go away on their own eventually, especially in the context of vaccines. So I think we'll have to the answer is really time will tell.
Well, thank you for all your answers to these questions. At this point, I'd love to reach out to our viewers and ask if you have any specific questions that you would like Dr. Carbone to answer. And in the meantime, while we're waiting for some responses from our live audience, I do want to ask, what about when cancer patients do test positive for COVID? If they're in active treatment, would they continue that treatment?
Yeah, that is actually a problem, because we want to protect not only them, but the people in our clinic. And so we usually wait, if a patient who's on active treatment gets diagnosed with COVID, we do not bring them into our clinic where there are vulnerable people, and typically would delay their treatment until they clear the virus. So that is an impact also on patients, and another reason to get vaccinated, because you don't want an active infection if you get it, even if you are minimally symptomatic or have no major manifestations of the virus, that it would impact your ability to continue with your treatment potentially, just to protect others in the clinic.
That makes sense. And we're seeing some questions about what if I become infected with COVID between my first and second dose? Would I still receive my second dose?
I'm sorry, what was the question?
So someone has gotten they're doing one of the 2-dose
Yeah,
vaccines. They've gotten the first, but then actually did test positive for COVID before they got their second dose of the vaccine.
Yeah, we had a famous golfer do that recently that lost a lot of money because of that. That's a good question. And I actually don't know. My assumption is that you would still want to get the second vaccine, but probably after you recover from the active infection. Because it's actually found that COVID infection may not give you as good a protection as the vaccine. So I think even if you've had the infection, I think getting the full course of the vaccine is important. Now, some people have said that the side effects, the flu-like symptoms that you get with the second vaccine may be worse if you've had the infection. But all of that pales in comparison to the consequences of getting a severe infection. So I think that that's probably something you should talk to your doctor about, but you likely should go ahead and get the second vaccine, even if it's delayed until the COVID infection has recovered. And I see another question in the chat about just a comment from someone who has stage 4 cancer on Opdivo and Yervoy and had the vaccine in February and everything is still stable. So just an example of how someone doing well continues to do well after the vaccine.
So we've definitely heard you say that there are very few reasons that someone with solid tumor cancer shouldn't get the COVID vaccine or should potentially, the one thing that you talked about was a potential delay if you have chemotherapy for when your blood counts are back up at higher levels. Do you have any other kind of thoughts that you want to make sure that anybody listening hears about COVID, about the vaccine, about being in active treatment while there is still a risk of COVID, or being a longer term survivor?
Well, like I started out saying, I think one of the biggest impacts of the COVID has been on the normal healthcare access of people without cancer or at risk of cancer. And so I would say that people should get vaccinated and get their normal health maintenance things right now, so that cancers can be detected as early as possible. Now, if you're an active cancer patient, that's possibly less of an issue, but if you're a 5-year survivor, as we've seen in the comments, you really should have all of your normal cancer screenings for other things. If you're a lung cancer survivor, you should get your mammograms and your colonoscopies. And all of those things are affected by COVID in terms of scheduling and people being afraid to go see doctors and go to clinics. But at this point, if having a vaccine enables you to really do these kinds of normal things and protects you against the delayed diagnosis of cancer. And in virtually every type of cancer, the earlier you detect it, the better. And often in the case of lung cancer, for example, if you have a smoker, a father who's a smoker, often the wife is a smoker too, and that person should be getting their screening lung cancer CTs, for early detection of lung cancer. And it's an older population that should be getting their mammograms and their colonoscopies and other normal healthcare maintenance things.
That's a really good reminder for all of us to make sure that we are getting back and getting those on the schedule that we should be getting those, because I do know that there was a lot of delay and those schedules have been moved back. when I went to get my mammogram, it took a lot longer because the line was of people ahead of me was a lot longer than it normally was. So for people to get thinking about that now.
Yeah.
I do see a comment from one of our listeners saying that they don't trust the vaccine because it was put together so quickly and that they honestly feel safer not getting the vaccine. Is there anything that you want to talk about in terms of that the vaccines did come to market so quickly?
Yeah. Well, of course, everybody's free to have their own opinions, but I think the vaccine was developed quickly for a number of reasons. First of all, thousands of the world's best scientists attacked this problem, with all their effort, and they weren't starting from scratch. This type of vaccine, almost 30 years ago, I was working in the laboratory on nucleic acid vaccines, and we were showing that they were very effective in the laboratory. This identical vaccine was developed for the SARS outbreak, but actually never was needed because the virus went away. And with science these days, in the last year in lung cancer, we've had, I think, 10 new drug approvals. So the pace of developing new drugs is accelerated for a very specific reason. And that pace is accelerated because we have better science, and we're designing our drugs because we know how to design them. And the same thing goes with vaccines. In the past, we used to develop cancer drugs by grinding up tree bark or scraping fungus off of rocks at the bottom of the ocean and seeing if it killed things in petri dishes in the laboratory. Now we understand exact structures of molecules, and we can say, like a tinker toy, you build a molecule that fits in this space, and then it works. It kills the cancer. With the vaccines, it's a very simple vaccine. We have the piece of the DNA from the spike protein, which we know from research is what the virus uses to bind to cancer cells. We put that piece, make an RNA sequence that codes for that piece, and you use that as a vaccine. So because science has advanced, and our understanding of viruses and our understanding of the immune system has advanced to such a degree, we can develop these things in very short order. So I think the speed of development is going to become commonplace. This is something that we do because we understand what's going on. We develop a new flu vaccine every single year, just exactly like the COVID vaccine. But people think that's safe, but it's a different vaccine every year based on new viruses. So there should be. I have a PhD in genetics as well as an MD, and from everything I know, the speed of development of this virus, the vaccine, should not be a concern at all. And the fact that it's been used in now hundreds of millions of people safely and highly effectively really should put you at ease that it's time to take the vaccine.
Well, we really appreciate you sharing your knowledge and your years of experience in research and genetics, and even knowledge of how these vaccines are put together. That's really helpful for us and for the viewers out there today. Are there any last thoughts that you want to make sure that we touch on?
No, other than please get your vaccines and make us all safe, and not just for your sake, but for everybody's sake and people around you.
Great. Well, At the end here, we want to thank our sponsor, Merck. It's with their generous support that we're able to give you information like this and be able to distribute it in ways like this Facebook Live. And also know that there's more information on COVID and cancer, as well as on lung cancer and many other cancers at cancersupportcommunity.org. Thank you so much.
Thank you, Claire.
Really appreciate it. Have a great day.